Okay, we're going to get started. It is noon, and I'd like to welcome you today to this fourth session on healthcare reform, special topics in geriatrics. This is, once again, is sponsored by the East Texas Geriatric Education Center and in partnership with East Texas AHEC. My name is Tony Danuzzo, and I direct the GEC. And I really, as always, like to acknowledge the assistance we receive from AHEC. They're really valuable for what we try to do. As you know, our mission is to provide enhanced geriatric education programs for health professionals and students in health professions. And this is a series that we've started in January, and it's the last session that we have, and it'll be covering what's really happening with healthcare reform, some of its expectations, and what could we expect in terms of future implications, if we could even do that much in terms of predicting. I want to just say, though, that as a fourth session, we've recorded all the previous sessions, and we are recording this one as well. We have DVDs available for the previous sessions. If you're interested in them and getting a copy, let me know, or I'll send out an email, general email, and you can contact me, and we can send you a DVD for any of the previous sessions that we've had. And I may be a little biased, but I think they've all been really good. Yeah. This is our agenda. You should have this in your handouts to have an idea of how this will go. This will be for 2 hours. The first hour, we're going to have Dr. Goodwin talking about realistic expectations of healthcare reform. Have a short break as we set up for our panel here that will be representative number of senior citizens in Galveston County to talk about some healthcare reform issues, their hopes, fears, how they deal with health. And then there's going to be some time for evaluation. The evaluation part is very important, helps us get some feedback and improves programs for later on. And so there's lots of forms available for that. There are handouts in terms of preparing health providers and students for upcoming healthcare reform changes as well. So hopefully you've gotten all that material. This is the purpose for the session, and it's really to give different perspectives on healthcare delivery, what we can expect with some of the changes, as I said, expecting resulting from healthcare reform and legislation that goes with it. And then we have the senior citizen group to give their perspectives. And I think that this is a really good way to round out the whole series. All right, it's a good way to end things, and then we can maybe see what we can do for next year. Your learning objectives are listed here. And the first two will be for Dr. Goodwin, and the last two will be for the senior panel. And we are doing broadcasting to different sites in East Texas. We have over here, we have, let's see, where are we? Lamar University here in Beaumont. Up in the top corner was, I think, SFA, top left corner. The top right corner is Victoria College. And then there's Baylor down in the bottom middle. Okay. And welcome to all those sites as well. Okay, we offer CME credits. This will be for 2 credit hours. We have evaluation forms that you'll need to complete. For that, we also offer 0.2 CEUs for social workers, and those forms are in the back as well. You need to complete your credit request form to get the credits. We offer 2 hours for CNE for nurses. RNs, LVNs could get a letter of participation and attendance if they'd like. And this will be, never mind the 1.83, this will be for 2 hours total. Again, there's a separate CNE sign-in sheet and evaluation forms and a request form for CNE. We have 0.2 CE contact hours for physical therapists and occupational therapists as well, and those are evaluation forms for them. If you have any questions about the forms, just let me know and I could help you with those. I need to say that none of our speakers today have any commercial affiliations to disclose. Okay, very important there. Any questions regarding the forms or any materials? Because I'd like to get started. Very good. Okay, I'd like to say someone who probably needs no introduction. Dr. James Goodwin is Director of Seeley Center on Aging. I'm not going to read his whole bio. Don't worry, we need this time. But I do appreciate his support for all our activities and everything that we've been doing. He's going to be talking about realistic expectations from healthcare reform. Okay, well, let's get going, and let's have Dr. Goodman talk about this.
So I'm going to talk about realistic expectations from healthcare reform because that's Tony's title, so I guess that's what I'm talking about. I see two major and equal motivations for healthcare reform. One is obviously to increase coverage, and that got the most press, and I'll give you a little data on that. And the other, at least equally important, though I think a lot of people in this country still don't accept it, is the need to control costs. And I'm going to be spending most of my time on sort of the cost side because that's the side I understand the best. I know it better. But I will give a little data on the increased coverage. I'm going to spend a little time at the end describing some other healthcare systems around the country, around the world. And the reason is that healthcare systems, if you look at them from one country to the other, some of them are designed. They sort of happened all at once, and some bright people sat down and said, what's a good healthcare system? And some of them have evolved. And it really doesn't have anything to do with the coverage. In other words, you can have systems in highly socialized countries that are more evolutionary, and you have others that are designed. We're obviously quite evolved. We've had some designed elements to our healthcare system, like Medicare, but then even that has evolved quite a bit since then. So let's focus on why people were concerned about costs. And this is a slide that many of you have seen various iterations of. This is 2000 data. You could do 2010 data. The pattern would be exactly the same. And this is an indicator of health. And you can use a lot of different indicators. This happens to be life expectancy in men at birth. And this is mean life expectancy. You could do it with median. You can do all sorts of stuff. You can do neonatal mortality. You can do lots of different indicators, and you get the same pattern. So here are all the countries arrayed out in terms of their life expectancy. Life expectancy is a nice indicator of kind of health, overall health, right? I mean, if you're dead, that's some indication that you haven't been healthy. And so life expectancy is a good indication. We have others. And then here is the per person, per capita spending on medical care. And so you see there's actually does seem to be somewhat of a relationship between per capita spending. And these are only in developed countries. You can do these things just in European countries, or you can include other developed countries like Japan, but you get kind of the same pattern. And then here's the US way out here, okay? And so this leaves many in this country quite skeptical about, well, we all know we're paying twice as much. As a country, we're paying twice as much on health care, and it doesn't seem to be helping. We all talk about how we have the most wonderful medical system in the world and all that stuff, but it isn't obvious from looking at life expectancy. It's not obvious at looking at neonatal mortality. It's not obvious at any one of a whole number of good health indicators. And you can say, well, that's because we have lots of immigrant populations and lots of different ethnicities. If you just took, to try to make this more comparable to the European data, if you just took United States citizens of European origin, all right? So, the type where the columnist writes in the Galveston Daily News, these are the real Americans, So if you just take Europeans of, Americans of European origin, it only increases that right up there. It increases it less than a year. So there you're comparing apples to apples, except these countries are actually getting increasingly more diverse, as you know. And still, the United States hasn't quite made it up to the UK, which is a very diverse country and spends less than half we do. So this is behind the drive for G. In addition to improving coverage, we have rather bad coverage compared to these other countries, and we don't seem to have relatively good health. This is a relatively recent phenomenon. Here's another indicator of health. This is just taking 45-year-old women, I think, taking 45-year-old women and finding out what percent of them are still alive 15 years later. And once again, you can rate countries. This was what it looked like in 1975, and here the axes are reversed. Here we have how much money per capita is spent on medical care. So in 1975, the U.S. still didn't look super good. It was still at the bottom in terms of this health indicator, which was, what percentage of 45-year-old women make it to age 60 in this country. But we didn't really spend much more money than anyone else in the world, our average per capita. But between 1975 and 1990, that changed dramatically. And here are data from 2005, but data from 1990 would have been about the same, which is everyone's life expectancy went up. The health of the developed world has improved rather dramatically. So now, rather than 45-year-old women having about a 93% chance of making it to 60, now the average in the developed world is about 96, 97%, with a lot of decrease in heart disease and some deaths, some decrease in cancer. But the U.S. now still at the bottom of the list, even perhaps a little more lagging than it was, while it has changed its relationship in terms of healthcare spending to the rest of the world rather dramatically. So we also tend to spend a lot. This isn't just government money or insurance company money or whatever. We also tend to have more out-of-pocket expenses than other countries. So in other countries, there is a tremendous variation among countries. So this is percent of the population that spends more than $1,000 a year in sort of out-of-pocket, not counting what you spend for your insurance premiums, but this is just sort of out-of-pocket expenses. And the U.S. is high at about a third, a little over a third of people have at least $1,000 a year in out-of-pocket for drugs and co-pays and all that. And it goes all the way down to the UK, which has probably sort of the most centralized, most socialized, most organized healthcare system in the developed country, where there's virtually no one who spends that much. But then Switzerland has a fair amount too. So there's a lot of variation here. But we do spend a fair amount out of pocket. This is another way of looking at healthcare. This was a series. Well, this was a series of surveys of patients with specific illnesses and also with physicians that were done in 5 developed countries. And then it's looking at the answers of the patients and rating these medical care systems of these countries based on the evaluation of these answers. Now this is wrought with all sorts of problems because you're crossing cultures here. So you might go into a culture where no one complains about anything. Take, for example, Canada. Where everything's nice and being polite to complain. So we are, we're getting into some potential problems. On the other hand, it's pretty impressive once again that on these subjective ratings by patients and physicians, the U.S. Doesn't come out looking good. We're towards the bottom. We're like 7th or 6th in a lot of those ratings, with a lot of variation among the other countries. Canada also doesn't come out looking very good. And then here are some objective, this long, healthy, productive lives is like some of that data I was showing you about life expectancy and all that. And once again, as I showed you earlier, the U.S. is the lowest. And then, of course, on per capita expenditures, it's twice as much as most of these other countries. So this is a source of, golly, is there a way that we can restrain healthcare costs? And this is real money. I mean, this is money that, if you're a UTMB employee, you see it deducted from your paycheck every month, right? If you're a physician, you may say, well, it's providing my paycheck, but it's also deducted from your paycheck every month. UTMB pays what, half or a little more than half of our health insurance, and we pay the other half. This is real money that would be going to us as income if we weren't paying for it, in addition to the out-of-pocket expenses. So I want to go through then reimbursement, so that I can then talk about the healthcare reform, and also just touch briefly on Paul Ryan's alternative to the administration's, to the Affordable Care Act, which got passed last year. So you can look at reimbursement. You can look at it from the physician's perspective. Often I give this talk mostly to physicians, and I'll look at it from our perspective, what does we have to do, or from the patient's perspective, which I'll look at it when I'm giving talks to patient groups, or from the economic perspective, which is, how does the money flow and how does that affect things, or from the quality perspective. And I'm going to be focusing mostly on the economic perspective in this talk. So in the U.S., medical care can be seen as an open loop. You have a patient going to a physician, and the physician decides, you could say in consultation with the patient, what else needs to be done, what kind of treatments they need, what kind of tests, what kind of other doctors do you need to see. And then the reimbursement for that goes to an insurance company. And in actuality, sometime in the early 70s, health insurance companies stopped being health insurance companies. They're not health insurance companies, they're claims processors. All they do is they just pay whatever comes through. An insurance company is at risk, right? Life insurance company, if everyone dies, or flood insurance we've done in Texas, or hurricane insurance, the insurance company can go broke, okay? That can't happen with any of including Medicare, which is an insurance company, okay? All of these insurance companies just process the claims and then pass the costs on to the payer, whether it's the federal government or General Electric or Union Carbide or UTMB, it just gets passed on. So no one's at risk here. And so it's an open loop, and if you think about a capitalist economy where cost is supposed to drive down demand, and you have a supply and demand type of situation, and if the cost gets too high, the demand goes down and then the cost comes down. It doesn't work here because no one's experiencing the costs. No one, it's an open loop with no feedback at the critical level of, say, the patient or the physician who might be able to make decisions. And some other countries, by the way, also have the same issue, and I'll get to that. So how did we deal with this? We made a valiant and ultimately futile attempt in the 90s to deal with increasing costs as medical costs were going from 8% of our gross domestic product to 12 to 13% and on its way up to 17%. In the 90s, the concept of managed care was developed and introduced. And managed care is a very nebulous concept. It just means that there's going to be some force in here that's going to try to manage this loop. Okay? It doesn't mean what it is. It's just a very generic concept. Anything that can be that can manage that. And there's various types of managed care. I just want to focus on HMOs because we went through a lot of HMOs somewhat traumatically in the 90s, and I want to talk about the Affordable Care Act. I want to refer back to what I've said on the HMOs. So for an HMO, as you all know, the whole key of an HMO is capitated. In other words, an organization assumes responsibility. Organization's at risk for providing all medically necessary care to someone for a set fee. So if that person requires 5 times as much care, that's just tough for the organization. It's got to provide the care. So the distinguishing characteristics of HMO then is you have a defined population. You can't be half in. You're either in or out. And then the organization has a responsibility for delivering medical care with a fixed budget. Typically, but not always, there tend to be a few financial barriers. The copays tend to be lower than in other systems. Risk sharing I'll talk about in a second. And voluntary choice of plan depending on who's telling you. In other words, like for Medicare, yes. For some employers, maybe there's not so much of a voluntary choice of a plan. So an HMO organization, it has to take responsibility for the entire medical care of someone, which means it's got to do something about drugs, and it's got to do something about rehabilitation, and it's got to do something about perhaps massage therapy, and it's got to do something if you're in an HMO in Houston and you get sick in Cleveland, or if you get sick in Europe. It's got to do something to compensate for all of that. So you need a large organizational structure to do that. Obviously it needs docs, and someone's got to pay for it. But it can be anyone. You can join as an individual, or your employer, or the federal government like Medicare, HMOs, and this administration then is responsible for holding all this together. So traditionally the HMOs in this country, starting in the 1930s and 40s, were what are called staff model HMOs or group model HMOs. This is the model, say, for group health. Has anyone heard of group health? Group health? No? It's a big HMO. It's big in the Washington, D.C. area, in the Pacific Northwest, and in the upper Midwest. And this is an HMO the way when people my age thought of HMOs. It's a big organization, and everyone belongs to the same organization. So the doctors are full-time group health employees. Everyone in the hospital is a full-time group health hospital, okay? They don't have non-group health hospitals they work with. They work just with those. All their services, their physical therapists, they're group health physical therapists. So everything is one thing. These things tend to change slowly because you can't exactly double your amount of services in 3 or 4 years if you're a huge organization like that, because you need twice as many hospital beds and twice as many cardiologists and all that stuff. So these are very stable organizations that have been rather well received by people over the years with some minor grumbling, but they don't respond quickly to change. And this is really the same, except physicians are cut out in a separate organization, but these are still full-time physicians, and this is called the group model HMO, which is Kaiser Permanente, which is the other big, huge national HMO. Once again, highly stable. They have their own hospitals, their own organization. They can't change quickly. And this is the thing that drove many physicians and patients crazy in the 1990s, which was called the network model HMOs. This was what, when I was driving to Houston, every week the billboard would change. You know, it was Aetna is now Eureka, you know, and then it was Eureka is now your Healtha, and you know, and they were very, as we say, dynamic. This is a network HMO, and a network HMO is something that essentially an entrepreneur could build in his or her garage, okay? In that the only thing you needed was administration, and then the administration, which would get the source of premium from someone, Medicare, General Electric, whatever, would then set up contracts with docs, with physical therapists, with pharmacies, with hospitals, but they didn't own any of these things. And these docs might have contracts with 7 different HMOs, right? All with different sets of rules. And this led to a lot of the dissatisfaction with HMOs in the 1990s. I don't know if you know, but in the 1990s, it was every year, it was an increasing number of people in HMOs. And the 1990s was the only time in the last 40 years when healthcare costs remained stable over time. They actually went down a little in the early 1990s because of this big growth in HMOs. But there was such dissatisfaction that they were essentially not exactly phased out, but fell into great disfavor. So the interesting thing about going from fee-for-service, which is sort of when you see a doc and that doc gets paid for seeing you, or when you get a drug and the drug company gets paid for providing the drug, to an HMO, is it stands all economic incentives on its head. Under fee-for-service, the more medical care that's given, the more hospitalizations, the more cardiac catheterizations, whatever, the higher the profit for everyone involved, right? And under capitation, where you're getting paid a certain amount to take care of people, then the less medical care, the higher the profit for people. The ideal situation is if no one ever gets sick, right? So this was a very chaotic thing to bring onto a medical system in a short period of time, to go from this thing to this thing, and very strange things happen. So what happens is profit centers become cost centers. So transplant surgeons who, normally the hospital will hire, 3 or 4 beautiful women to go before them and to scatter, rose hips or whatever in front of them, and they not only have the choice parking spot right outside the hospital, frequently they can drive through the lobby onto the elevator to the transplant floor. Suddenly, these people are pariahs. Because what do? They do all this expensive stuff on an HMO, right? So then they're told, well, you can park downtown and take the trolley, right? They say, well, the trolley isn't working. They say, wait for it. It'll start in a couple of years. So suddenly the whole financial motivation of the organization changes. It's very chaotic. So then how do you control costs in, I'm not going to do that. How do you control costs in HMOs or in any managed care operation? Well, one thing you do is you design treatment protocols or algorithms. You get some people together and you say, what is the best treatment? Because as I showed you earlier, we seem to be spending twice as much and we don't have any outcomes, so there must be things we're not doing right. What's the best treatment? For example, you can take people who are very, very high utilizers of medical care, like people who are always in the emergency room with diabetes or congestive failure, and you can assign them, say, a nurse case manager, like an advanced practice nurse, who works with that person all the time, and that saves enormous money. So an individual physician can't do that, nor is an individual physician motivated to do it, because that's actually a source of income every time they get hospitalized. But under an HMO, this makes a lot of sense, trying to come up with ways to reduce utilization, and practice guidelines are the same thing. So I want to now go through, with that sort of introduction, I want to now go through what's happening with the Affordable Care Act. So in 2010, to try to give people something right away that they would feel good about, the first thing that came on was coverage for young adults. And this just tore me in two, because I had a 25-year-old at the time. I think she's 26 now. But I had a 25-year-old who was just falling off my insurance. But it was like 3 months too late. It was 3 months too early, actually, that she fell off my insurance. So because it was 3 months too early, we couldn't get her because what this does is it allows kids 1 extra year on their parents' insurance. And that's no small thing. That's, for me, it's $4,200 a year to insure this perfectly healthy, 26-year-old who never sees a physician. Another popular thing was that insurance companies could not deny coverage because of pre-existing conditions. Another a sort of symbolic thing was a rebate in the donut hole, and I'll get to donut holes later. But in 2010, that rebate was only $250. So in 2011, there's the beginning of more requirements for physician quality reporting. That's going to be phased in over 5 years. There are new payment and delivery approaches, which I'll get to. They're going to start funding demonstration programs, particularly with Medicare. And the donut hole discount. So the donut hole, as you know, under Part D in Medicare, Medicare now helps with drug costs. So the first $360 of drug costs a year are your pay, or your responsibility. And then the next $2,300 or so, Medicare pays 75%, the person pays 25%. Then you go into the so-called donut hole, where from about $2,800 up to somewhere around $6,000, $5,800, $6,000, you're responsible for 100% of the drug costs. And then over that $6,000, Medicare once again comes back in with 95%, paying 95% of the cost. So if you're a high, and for those of you who prescribe drugs, you know that these, it is not unrealistic that someone might be spending $3,000 or $4,000 or $5,000 a year on drugs. Then every additional prescription you get, you're paying the absolute price for, with no insurance. Now this, like many things in the Affordable Care Act, was not designed It was backroom dealing at the last second, trying to find a way to say we could, do it without busting the deficit or something like that. But things like this happen when a bill like this is designed. It's not like you just get a bunch of bright people in a room and they come up with the best plan. So the donut hole discounts, which start this year, are gradually over, I think it's a 5-year period. You start getting discounts on drugs. If you spend more than $2,600, eventually the discounts are going to be up to 75%. So it's going to be kind of like what it was in the $300 to $2,600 range. But it's going to phase in over several years. The only thing interesting that's happening next year of great interest to physicians and physician organizations are accountable care organizations. Accountable care organizations are an organization that says we're going to take responsibility for the health of this set of individuals. Sounds very much like an HMO. An HMO says we're going to take responsibility for the health of this set of individuals. But the difference is the accountable care organization, at least initially, is not going to be at risk. So for example, they'll come to a physician group like us and say, okay, so the average cost for a Medicare patient in Galveston, Texas last year was, say, $4,300 or $1,800 per member per month or whatever it is. And they'll say, we will give you that. And if the total costs for that person are lower than that, you get to keep half of what's lower than that, okay? So, but if the total costs are over that, you don't have to pay anything. So initially, accountable care organizations, the physician groups are not at risk, and they can only benefit by trying to keep costs down with strategies like case management and putting people on protocol, particularly paying attention to these people who are very, very high utilizers, because it's the top 5% of patients who, or just don't have good continuity of care and they're always bouncing back and forth that wind up in the hospital all the time and costing so much money. The other thing that makes it difficult to understand whether this is going to work or not is that the accountable care organizations don't actually control the patients. In an HMO, you can say, look, it's my way or the highway, unless you want to quit. But as long as you're in this HMO, you have to get all your care from this HMO. That's part of the deal. It's cheaper, but you got to get all your care from us. But in an accountable care organization, patients can get care anywhere. So they can still keep on doing things. So it's very dicey about how big an effect this is going to have on cost control or in terms of quality enhancement. I like administrative simplification. This was always put together by an administration source, sure, administration simplification. When did we ever see administration simplification? Payment reform, and then they're going to start. They're going to start covering more preventive services in Medicaid. 2014 is the big year for the Affordable Care Act, not for Medicare patients, but for the rest of the country. That's when the feds say, just like with Medicare, Medicare has for the Medigap insurance, they have a definable thing. Medigap, they can't come in and say, we're going to give to Medicare recipients this additional insurance. It has to be one of these 10 plans, which the feds have said, here are defined expectations for insurance. Well, now that's going to be true for all health insurance, that if you offer health insurance, you've got to cover hospitalization. If you offer health insurance, you've got to cover certain preventive services, stuff like that. The Independent Payment Advisory Board is the other major mechanism whereby they hope that this will cut down costs. It's people like me sitting around saying, well, why are we doing so many hiatal hernia surgeries? Hiatal hernia surgery seems to be you're 3 times as likely to get it if you live here than here, and no one's ever shown it seems to work anyway. So maybe we should stop paying for it, or at least maybe we should increase the standard of evidence that the physician would have to give before we reimburse for it. So in other words, death panel. Okay, so So the independent payment advisory boards are supposed to be then working with Medicare to say, look, some things shouldn't be reimbursed because they don't work. In fact, they're harmful. Lord knows whether this will work because this is all done in a political context. I mean, we decided 7 or 8 years ago to limit physician reimbursement under Medicare, and every year Congress passes a law postponing that one more year. And so, you know, the problem with some of these things that are put off in the future is by the time we want to do them, it's not clear that there's going to be any political will for it. Premium subsidies, which means that the feds will, you know, give premiums to low-income people so that they can pay for health insurance. This is obviously a list put together by someone in the federal government. This is called shared responsibility for coverage. That means you get fined if you're not covered. That's shared responsibility. So this is what a lot of people object to, which is that if you don't have health insurance, then you're going to have to pay for that. Insurance exchanges, along with the essential benefits, will try to keep costs down. Medicaid will expand to cover much higher proportions of people, and it's going to be more regulated at a federal level rather than state. And then we're going to be trying again, the federal government is going to be trying again to encourage people into these managed care plans. And then the only other thing that happens is that high-cost insurance plans start getting taxed in about 7 years. It really is really high-cost insurance. I mean, I think it was at $11,000, and I calculated, you know, that's for an individual insurance, and so I calculated UTMB, and that's the UTMB plus, you know, the employee's contribution, and it's something like half that now. So I'm sure there are, you know, plans out there like in General Motors or whatever that are very, very expensive, but originally this is going to hit very few people. Now, if it's not indexed to health inflation, then what will happen is it will hit an increasing number of people, say 10 years, 15 years out. So in terms of coverage, in 2014, there should be a rather dramatic change in the people who have health insurance. This is, you could put together, just like with the economic data, you could put a lot of different indicators. This is just women 19 to 64 who don't have health insurance by state. And so this is sort of what the current situation is. And this is what it would look like after the Affordable Care Act. So the states that have the highest undocumented immigrant populations tend to have the highest uninsured populations. And even after the Affordable Care Act, you see that these states will still have. Texas currently has, I think it's 24%, but I'm not absolutely sure, that are without medical insurance, without health insurance. And that will go down to about 14% under the Affordable Care Act in 2014. And the people who will still be uninsured are mostly, the bulk of them are undocumented, but there are other categories also. That's why Arizona will still be the highest, because they have a very high level too. So it does have a rather strong impact, cutting in half, essentially, the number of people without health insurance in this country. So other models of healthcare. Let's pretend if we were just going to design a healthcare. We started over again, which you can never do, right? Because once something is going, all you can do is sort of try to twitch about at the edges. But if you were going to design one, you know, you'd want local-based. You want neighborhood doctors, you know, and then your gastroenterologist, your people who do endoscopies and cardiac casts and something like that. You don't want neighborhood. You want in big population, even if people have to travel 20 or 30 miles, that, you know, they're all centralized and they have high volume and good quality. And then for your coronary artery bypass grafting and all your real fancy surgery, your appendectomies you can get here, but your fancy surgeries you want to get at the big old medical center where they're very, very good. So in an ideal system, you don't have many of these. You have tons of these. And the closest to that is actually Great Britain because it's designed. It was designed actually after World War I and then again after World War II in 48 and 52. And this is sort of this is a model for Great Britain, which is they pay nothing. Everything comes out of general taxation. It's not even a Medicare or health tax. It's just general tax dollars, goes into the National Health Service. General practitioners is evolving now, but typically you're paid by the number of people in your practice. So, you know, if you have 2,000 people, you're paid a certain amount. If you have 3,000, you're paid 50% more. The specialists are all on salary, so that sort of cuts down any economic incentive for them to do too much. It also gives them, it's not an incentive so much to do too little, but it cuts down on that. And then the hospitals have a global budget and have to be negotiated every year. And all these things have to be negotiated essentially through this about how are we going to spend our money with whatever budget the government gave us. Canada is a little more complex system in that the primary care docs in Canada are kind of still fee-for-service, and the specialists are kind of still fee-for-service. It's a negotiated fee-for-service, but they have a system where the docs really get paid for how much medical care they give. And then they have the hospitals and everything else, all the nurses and all that, community nurses, are all based on a global budget that's at the regional level. I looked at a job about 3 years ago when UTMB was going through some trauma or another to be head of this regional health authority in Vancouver Island. I get to live in Victoria, and you know, which is this precious little town, which gets cold. But I would have had, I can't even remember, it was a $450 million budget. And I could have spent it any way I wanted. You know, lollipops, we're going to decide lollipops. No, I mean, like, but for example, you know, I'm a big believer in community health nurses and, you know, getting community-based care and getting advanced practice nurses out in the community taking care of either very sick people with diabetes or heart disease or the frail elderly. And it was just a wonderful thing to think about that I could actually have an influence in that. On the other hand, my personal income would have gone down considerably moving to Canada, and that was enough to keep me here. Okay, so here's I forget, I think this is the Japanese model. I just showed this one because it's so complicated and it's very much like ours in that, you know, the workers in the big firms plus the workers, they get an insurance plan that way. The workers in the small firms and people who aren't working, the government subsidizes. You know, the firms will do a little and the government subsidizes a little. But basically everyone has health insurance. In Germany is probably the most evolved of any. Germany is sort of the least designed health system, and it was because it was put into place by Bismarck in like 1890 or something like that. He put in a system to try to guarantee universal health care for the population of Germany. And what's happened is they've been tweaking it ever since, and it's a combination of the government paying into these sick funds and in many areas of the country where they have strong labor unions, it's the unions or it's the employers. And then something happens, that's that, as it always is. And then the hospitals get paid and the physician associations get paid. There is kind of a fee-for-service situation, so there's always pressure for costs to rise in Germany, just like in this country. But what happens is there's very, very tight control on how much will go into these budgets, and the physicians in the hospitals are sort of well represented on these boards that say, okay, here's what you have. You have you know, $120 billion. How are you going to allocate it, and what are we going to pay for, and what we aren't? The proposal put together by Paul Ryan in Wisconsin is very complex, and it has many of the same things, or it addresses many of the same issues that the Affordable Care Act does. But the major thing is in terms of Medicare, and this is what got everyone, so that's what hit the headlines and all that. It doesn't affect people, his plan doesn't affect people who are currently 55 or older. And then what it does is it implements a voucher system for when those under 55 become eligible for Medicare when they turn 65. They get a voucher, and then they get to shop for the best deal among a lot of different insurance companies. One thing that was very rather courageous in this plan was, and also was actually less courageous in the Affordable Care Act, was it dealt with the fact that this country can no longer afford to pay the health insurance, or for that matter the Social Security benefits, for people who might be making $250,000 a year from their investments or whatever else. And so this was the first serious attempt, because the whole Republican Congress voted for it, to say, look, for people who make $250,000 a year, we're not going to be supporting them with these vouchers. And of course, that blew up in their face, because these are the people who vote for them. But still, it was a courageous, I thought, a very courageous move to make. So, in terms of the major financial criticisms, people have been lobbing, as you know, grenades at these things on a whole bunch of reasons. And I think, Mr. Ryan said, well, this thing is going to get demagogued, and that's exactly what President Obama said about his plan too, and they both have. But here, from a financial perspective, once again, not from the perspective of the patient or in terms of coverage, but just in terms of how well it might deal with the coming catastrophe in medical costs, the Affordable Care Act seems to me to be overly optimistic in its ability of things like the Advisory Commission to control costs. So it isn't clear to me, particularly since these things are going to be sitting right next to Congress, that these things are going to really be able to bring costs down. And the major criticism of the Ryan proposal is that it will control federal costs, because it'll say, hey, look, we're going to give you a voucher, and that's all the federal government's going to do, so it knows exactly how much it costs. Those vouchers are going to rise each year by general inflation, but medical inflation rises quicker than general inflation. So the thought is 10 years out, those vouchers are not going to be worth as much as what we're going to need. That's a criticism. But the major criticism from the financial perspective is that there's really nothing in there to control overall medical costs. And so what this is doing is it's getting the cost away from the feds, but it's shifting it to states and individuals. Now, one could argue that if it shifts it to individuals, that could have a beneficial effect, because then people would say, well, I'm not going to pay for that. They would start questioning more some of the medical procedures that they were being given. So I could have talked about lots of different things, obviously. It's a huge subject, but medicine is sort of the major cultural institution. In other words, it's like education is a huge cultural institution, or religion is a huge cultural institution. You don't want those things to change quickly. People, especially young people, are always arguing that things move too slowly, right? That gee, we ought to be doing revolutionary change. But it's perhaps a good idea that these big, huge cultural institutions change very slowly, even if they're doing a less than optimal job. But when they do change quickly is when, in other words, revolution, when everyone says the sky's falling, when everyone perceives a major crisis, right? So if you perceive a major crisis, like we got this, the feds increased the Social Security retirement age when there was enough, back in the 80s, there was enough people shouting, we're going broke, we're going to go broke, we're going to go broke, to where it was a crisis and where the Social Security retirement age got gradually increased. It just isn't clear to me I see a major crisis, but I don't necessarily think that that currently sort of majority of the American people see it as a major crisis. They see it more as there are people that you can sit next to in a bar or sit next to in a gas station or whatever, who after a while will say, well, there's plenty of oil out there. There's plenty of oil out there. They're just hiding it. They're keeping it in the ground just to keep the prices up. Now, there's a lot of people there's a lot of responses like that about healthcare. Like, we don't really spend twice as much on healthcare. That's just fooling with figures. Or our health is much better than the rest of the world. That's just fooling with numbers. There are a lot of people who don't want to sort of come to grips with the fact that we really do seem to have a rather a huge financial threat with these escalating health costs. So I don't know. I have been so wrong so many times in my careers about what would happen with health care. I have no idea whether the Affordable Care Act is going to survive. What was the Medicare thing that got passed maybe about 15 years ago and they got overturned 2 years later? Remember that? It was good, whatever it was. And I thought, this is great. And then it got overturned 2 years later. And so it's just, I think it's really hard to know. I think there are some people in Congress, particularly in the Senate, on both the Republican side and the Democratic side, who very strongly believe this is a major national issue that has to be addressed. But I'm not sure we are going to, nor am I sure how it would look like.